Today we're going to do another series of our kind of toxicology mini case conferences. So we've got 3 cases today. I am in one of the named conference rooms at the VA. It's like Mahogany or something. And we've got like roughly 8 or 9 residents over there who are going to participate with us. And we're going to go from there. So with that, we've got 3 cases. These are our 3 cases here. And we'll go through some mini teaching points for each one. If you were the resident who took care of any of these people and you're on the call, feel free to chime in at any point and give us kind of your perspective on the case, things you learned, et cetera. So with that, for the conference room here, which one do you guys want to start with? All right, so Jess immediately yelled out snakes. So we are going to start with snakes. All right, so you have got a 53-year-old man with no known past medical history, 53-year-old woman with no known past medical history, presenting with a rattlesnake bite to her left ankle, followed by rapid onset respiratory distress and airway swelling. So brief history, she was outside walking her dog, who's about a 15 to 20 pound dog, when she saw a rattlesnake. She sacrificed her body for the dog and dove in front of it, and the rattlesnake bit her in the ankle. So she presents to an outside ED where she has very severe respiratory distress, and she is ultimately, they attempt an intubation, which is not successful, and they immediately then perform a cricothyrotomy. So here's an X-ray of her post-cric imaging. And we don't often see a lot of people with crics. We don't see that a ton, but the teaching point here is if you can sort of trace this endotracheal tube down into her right mainstem. And so the trachea or endotracheal tube is entering there where the cric is, and then it immediately curves down. And so they put this in the right mainstem, they retracted it, and then her oxygenation got better. So she is there at the hospital with her progressive airway swelling, her respiratory distress, and they call you at the U for transfer. So I want you guys to pretend in the room that you are the admitting attending in the UCH MICU, and what questions are you going to ask? Great, so a question about vital signs. So she is hypotensive. They just started her on Levophed. She's at 0.05 mics per kilogram per minute of Levophed. So she is in shock.
So they already pulled back the tube?
They already pulled back the tube. Yes, they did. So they gave her IM epi times 2. And then after you say that, they are starting her on an epi drip. No blood coming out of the tube. And Sam is saying how hypoxic in her vent setting. So she is what the ED attending outside says she's on sort of minimal vent settings, which in this case means that she's got an FiO2 of 40% and a PEEP of 5. Great. So Melanie asked the big question, which is, did they give this person or do they have any anti-venom? And Melanie, the ED attending says, what anti-venom are you talking about? Awesome. So Melanie says the one for rattlesnakes. And does anyone know in the room what that name is? So Jordan says Crowfab, which he's essentially correct. So the trade name for it is Crowfab. And so they said, yes, we've got Crowfab, and we are going to go ahead and give her her first dose. All right, so she's transferring to you guys. You guys have called your toxicology consult, and we are going to go from there. So she comes to the U, and she gets some basic lab work done. And this is her kind of initial set of labs here when she rolls in. Is there any other labs that you guys want to obtain right after she rolls in and gets set up in her bed at the U? Coags. Cool, coags. So why do you guys want to get coags? Awesome. So Steve says that most snake venom makes some impact on your coagulation factors, which is great. So you guys go ahead and you get coags on her. And these are her coags right here. All right. So these are her coags. These are her coags. And what do you guys think?
What's her leg look like?
Say it again.
What's her leg look like?
What does her leg look like? Great. So Melanie immediately saw the coags and she was like, those aren't super suspicious. So she said, what does her leg look like? And you are in luck because we have a leg. So here's her leg. The marker was expertly marked by your admitting resident, your colleague at the U. And so where on this leg is her actual bite? So it's these two dots right there over her medial malleolus. Those two dots are the fangs of the snake, and that's where her bite was. And so what questions do you want to ask her about this leg right now? She's correct. So actually, what questions do you want to ascertain? That's a better, Melanie called my bluff there. What questions do you want to dive into about the leg? So we hear sensation, which is great. What else do you want to know about this leg? Pulses, okay. Say it again, Jess. Cold, great. So is it cold? Okay, so can she move things? Does she have neuromuscular function there? And then the very last one that you want to know is you want to basically, there's a time mark there on the marker to show when it was drawn, but you want to make sure that you know sort of rate of spread. All right, so I'll tell you, so sensation, she does have sensation. Pulses, she does have pulses. The leg is not cold. She can move her toes, and the rate of spread appears to be fairly quick. So is that concerning or not concerning?
Concerning.
Great. So Levi, our future allergist, says concerning, which is great. And so this person has a pretty concerning snake envenomation, and she needs further treatment. So what do we do next? Like, how do we treat this further? Great. So Melanie says, do we give more anti-venom, which is, I think, the appropriate guess because none of us, at least I've never treated a snake bite, never heard of a snake bite on an inpatient service until this. But Melanie is exactly correct. So we give more anti-venom. So let's talk about rattlesnake bites. So here is a cartoon rattlesnake. So when you're talking about rattlesnake bites, there's basically two big things you want to talk about. So there is kind of what is your envenomation effects on one side, and then how do you manage this person on the other? And so you guys hit on one of the biggest envenomation effects Steve did, which is you have problems with coagulopathy. Does anyone know why you have problems with coagulopathy?
Which factor it basically inhibits one of the major factors, and so you have basically inability to clot, and that's how they show it, right? They just make them bleed out of time.
Nice. So Steve says, I think there's a factor inhibitor in there, which there is, but the bigger issue is that snake venom has essentially like a thrombin-like substance. And so these people present with basically low fibrinogen, low fibro, prolonged PT or PTT, and they often also present with basically low platelets as well. And so clinically, this looks a lot like DIC on your labs, but there actually is apparently some controversy that this isn't true DIC because it's a thrombin-like substance and not necessarily excess thrombin like our own bodies produce. All right, so you've got coagulopathy, and I'll tell you guys that happens in roughly 40% of people who have envenomations. The other thing you guys hit on is sort of local tissue effects. And so her leg, and so the local tissue effects, so snake venom has a bunch of substances like hyaluronidase, which I'm going to try to spell on the fly, which essentially breaks apart tissue planes and causes spread. And so the worst case scenario here is you get tissue necrosis and essentially gas and death of the subcutaneous tissue. What else do snake venom bites cause, or snake bites cause? Great, so they can cause compartments and things break down enough. So Jordan says, great, so neurotoxic. So some snakes are indeed neurotoxic. We'll just jump ahead. One of those is the Mojave rattlesnake, which hopefully none of us ever come in contact with. And then what did this lady present with? Yeah, anaphylaxis. So angioedema and anaphylaxis are actually, believe it or not, like a pretty rare cause of snake bites. It's like roughly like 1% of people have angioedema and anaphylaxis. So she had the unlucky occurrence of getting bitten by a snake and the even unluckier occurrence of being one of those 1%ers who got angioedema from that snake bite. And there's like a funny comment in one of these papers that says like people are more prone to angioedema if you've been bit by snakes more. So if you are a repeated snake bite offender, watch out. So start to include how many times you've been bitten by a rattlesnake in your history. All right, so those are the big ones, those envenomation effects, so sort of 4 big 4. And then sort of the other interesting fact about snake bites is that about 25% are what we refer to as dry bites. So you can get bit by a snake and you've got about a basically 1 in 4 chance of having no venom be in that bite, in which case you would just have like the local tissue pain of having 2 fangs go in. Okay, so like you guys talked about, the most important thing is transferring these people to a place where we know what we're doing. We have a toxicologist, we have people who are familiar with snake bites. And number 1 in that list is supportive care once they actually get to the ICU. So managing their shock, managing their bite, et cetera. Number 2 is wound management. So cleaning out the wound, giving them tetanus, making sure things don't progress. And number 3 is Crowfab. So does anyone know what Crowfab is short for?
Isn't it like crow, like the snake species or something?
Yes. So Evan Zayer pulls out his deep snake knowledge. He is correct. So it stands for Crotolinae or Crotolidae. That's the subfamily that these snakes are found in. And then FAB is just your, sort of the immune part that it binds to. So it's a Crotolidae antibody. And so what poor animal do we synthesize this in? That would be sheep. And then just because I know that Levi is on the call, does anyone know what the fun contraindication to Crowfab is? It is a food allergy. Yeah, so Melanie inexplicably knows that. But if you have a papaya allergy, you cannot get Crowfab. I have absolutely no idea why that's the case, but yeah, so papaya allergies, watch out for that. So Crowfab. So what snakes does it work for? Does anyone know?
Everything in the Crotolinae.
Great. So yeah, everything in the Crotolinae family, which includes rattlesnakes. So the eastern diamondback, the western diamondback, the water moccasin, the cottonmouth, and the Mojave. And so if we scroll back up to our initial picture up here, these are the 4 snakes which are covered by Crowfab. And the reason we give Crowfab and not some of the others is that the water moccasin and cottonmouth are only covered by Crowfab. And so you have a broader net of snakes that you're covering. So you guys mentioned already, this person got some Crowfab in the outside hospital. How do we determine whether to give them more Crowfab? Essentially, how do we dose this?
I guess the symptoms like spread their foot.
Thanks. So Melanie's like apparently expert snake management. Yeah, so basically what you're looking for is, does it get worse? And so if your snake bite is getting worse, you redose. And when you redose Crowfab, you're basically giving them 4 to 6 vials of the medicine in about 250 cc's of NS, and you're infusing that. The interesting thing about Crowfab, kind of similar to Narcan and the oxycodone and sort of reversing opiates, is that Crowfab's half-life is shorter than Venom. And so the reason you have to redose this medicine is that the Crowfab is going to wear off and the Venom effects will still be there. And so oftentimes people will need these initial doses, then they'll need maintenance doses, and it takes anywhere from like 24 to 48 hours before the Venom is out of their system. The stupid question I asked during this is like, should I suck the venom out of the wound? Should I put a tourniquet on my arm if I get bitten by a snake? Does anyone have guesses on that?
Don't suck it out.
Yeah, so don't suck the venom out of your arm. So the reason you don't do that is there's like an official recommendation from whoever the snake management overseer people are that you just increase your risk of secondary infection. So the number 1 thing is get away from the snake. Number 2 is go to a hospital. And number 3 is be appropriately treated with Crowfab. And ideally, you want all this to happen less than 6 hours after the snake bite. That's when it's most effective. And that's Crowfab and rattlesnake envenomations. Does anyone have any questions about Crowfab, snakes?
But if you get bitten by a snake, you don't know what this is. You just go in and there's some symptoms.
Yeah, great question, Paul. So yeah, so if you're bitten by a snake and you're having like the coagulopathy, the local tissue effects, and you look like you're in the Crotolinae subfamily, the recommendation is to give Crowfab and monitor. The Crowfab is associated with some adverse effects. There's like some people get serum sickness from it, which happened at the U, and then there is a small rate of allergic reaction to it. But overall, it's a fairly harmless medicine.
And Danny, I just want to highlight Crowfab was such a game changer. This is Mark. When it came on the market, because before you used to need to know exactly what type of snake it was, because there was some specificity to the antivenom, which is obviously quite problematic. But along those lines, like you mentioned, it covers about 98% of the pit venom vipers in the United States. But if somebody is an exotic snake handler and has a king cobra, you know, from the Asian subcontinent or something along those lines, like Crowfab will probably not cover that. So it is good if you can know like what snake it is, but the specificity now, if it's at least a domestic North American snake, is not as important as it was before Crowfab came around.
Nice, that's awesome. Yeah, that's the other fun thing is that pit vipers. I actually didn't know this until I was looking at this last night. Pit vipers are just another name for rattlesnake. It's an interchangeable term. Great, that's awesome. Yeah, so basically, if you're practicing medicine in the continental U.S., someone gets bitten by a snake, give them Crowfab. Do not try to obtain the snake for further testing. So just get away from said snake. All right, so let's go back to our top board up here. So that was our first one. We checked off rattlesnake envenomation. We've got 2 left. We've got Elmer McGee, and we've got this bottle of potion. Got to vote for Elmer McGee in the room here. I made this last week, and I plan on using it until the day I die. All right, so this is another patient from the U over the last month or so. Some of you may have taken care of this person on the COVID floor or in the MICU. So he's a 41-year-old man with obesity. His BMI is 50. He's admitted for COVID, intubated on 12/2. You are coming onto service 3 weeks later, and he's been persistently febrile from 38 to 41 without any organism identified on culture. This right here is the day of intubation. That's 12/2. And this right here is his first fever. This line right here is 38. So you guys are pretend this is your first day on service. You're picking him up. You're pre-rounding in the morning. What do you want to know about this fever? Great. How high is it? So his Tmax has been at various times like roughly 41. Yeah, great. So no clear timing. It's just sort of always febrile. He is getting Tylenol, 1,000 milligrams, Q6 hours scheduled, and he has been from roughly, we'll say, this point forward.
What medicines is he on?
Oh, Levi, I love it. Before I show those medicines, Melanie, why did you ask about Tylenol?
Because if he's only, well, it needs a fever.
Great. So Melanie's saying maybe this fever is actually higher, so maybe the temperature is actually higher than we think, or it's something that Tylenol doesn't work for. And that's like a good way to think about when Tylenol is not working. All right, so Levi wants some medicines, and we will give Levi some medicines here.
And also, does he have a rash?
Yeah, Levi, great question. No rash associated with this. So here are some medicines. So we've got his current medications, and then he has his infusions and his rates. So I'm going to give you guys about 30 seconds to look at these, and then I want some takes on these medicines. All right, so people in the room, what do you guys think about his medicines? Which medicines stand out? Which ones are you concerned about? Okay, we got Precedex. Every single antibiotic. Propofol. We've, I think it was Logan in the chat said that anti-epileptics are a common cause of drug fever.
Even the Seroquel, if it's a high enough dose, kind of NMS type of thing.
Okay.
Fentanyl.
Fentanyl. What are you concerned about with fentanyl?
It's like a drip, but it can like prolong, if you have prolonged exposure, you get like serotonin syndrome.
Okay. So Evan's invoking with like a prolonged fentanyl infusion that maybe he could have a serotonin syndrome causing this fever. That's great. So you guys hit on all the big ones. So of these medicines, there are some pretty concerning ones. So all the antibiotics, like Connor said, you got Seroquel, like Carl said, valproic acid, Logan, and then fentanyl, Precedex, and propofol. Okay. So you guys have not examined this person yet. You've been sitting there at the front of the NICU pre-rounding. Anything you're going to change about your exam when you're in the room with this guy? Is there anything you would do that you wouldn't do for your typical ICU patient?
Look for thoughts, for signs.
Okay, going to look at his extremities for clots. Great.
Like reflexes and Clonus.
Awesome. So Connor says he wants to look for reflexes and Clonus, which he does. So here's a video. I'm going to play this while you're examining the patient. This is the person's leg. I'll play that again there when it's done. So what are we looking at here?
It's Dr. Sam King's badge right there.
Yeah, we're seeing Sam King. So Sam King is the resident performing the exam, while a chief resident who asked if he could film said exam is standing across the bed.
So yeah, like 3, 4 beats.
Great. So we're seeing roughly like 3 to 4 beats of Clonus. Awesome. And so Clonus, right? So Clonus is essentially it's a severe form of hyperreflexia where one reflex or one muscle twitch triggers a series of muscle twitches, which causes the beating of the foot. So does knowing this person have Clonus, 3 to 4 beats of Clonus on their exam, does that change your guys' differential for this?
And if they have increased quadriceps as well.
Steve, say a little louder.
Would depend if they have increased quadricep tone as well or not.
Okay. Would depend if they've increased quadricep tone.
3 to 4 beats doesn't seem like drastically abnormal, but like if there are other neurologic findings, then you would bump up kind of like NMS or serotonin-like syndromes.
Nice. So you're saying if they have Clonus, but they have other neuro findings, you bump up your probability both NMS and serotonin. That's great. Connor, did you base that on anything, or is that just sort of like your gestalt about thinking about serotonin syndrome and NMS?
I don't know. I just thought.
Nice. That's great. So I'll tell you guys, there actually is a diagnostic criteria for serotonin syndrome, which is sort of indirectly what Connor was just referencing. So referring back to Elmer Fudd at the beginning, does anyone want to take a guess at what the diagnostic criteria for serotonin syndrome are?
I think one of them is.
What's the name of that criteria first, Carl?
I don't know.
So it's called the Hunter criteria. So Corey was hunting a wabbit. All right, so the Hunter criteria. So Carl, what were you saying? What are some of these criteria?
You have to have A, an offending medication, B, and like, yeah, I guess temporal is part of that. You have to be on an offending medication, and autonomic instability, fever would count in this guy. I don't know if he had tachycardia, hypertension. Diaphoresis is often in there. I don't know if that's officially on the criteria. And then, yeah, hyperreflexic Clonus, not necessarily rigidity. That's more NMS.
Nice. So Carl basically hit on like 3/4 of the Hunter criteria right there. So the big one is you need to have a serotonergic medication. And then if you have a serotonergic medication, what are you looking for? And so the big one is spontaneous Clonus. And so if you have spontaneous Clonus and a serotonergic med, you 100% have serotonin syndrome. Essentially, there are 97% chance based on the Hunter criteria. The next thing you look at is, like Carl said, agitation and diaphoresis, which is not enough by itself. If you have that, you need to have inducible Clonus, which is what Sam King was demonstrating in that exam. That's what we do when we examine people. If you have the autonomic symptoms, then you also need to have inducible Clonus as well. And then the other weird one is that you can also have ocular Clonus. And so I actually am waiting to have a video of this in real life, but you see the eyes essentially fluttering up and down in the head. And if you have ocular Clonus, you also need to have inducible Clonus. And so the moral of the story here is autonomic changes body parts that are moving freely or moving after you examine them, and any sort of fever with a serotonergic med meets criteria. So the Hunter criteria, like we said, it's about an 85% sensitivity and a 97% specificity. And so the Hunter criteria actually performs better than a trained toxicologist for diagnosing Hunter criteria, sort of based on their like clinical gestalt. Any questions about the Hunter criteria?
Does the Clonus have to be kind of global or maybe lower extremities or somewhere?
Yeah, Kate, great question. So Kate asked, does the Clonus have to be global? And the answer is no. And so actually the most common place to see Clonus, does anyone want to take a guess? Yeah, so it's great. It's the ankle, which is great because that's the only place we examine for Clonus. But the ankle is the most common site for Clonus on the body. And so, Kate, if you just examine their ankles or just examine sort of their wrists, that's enough to diagnose Clonus. And then, like you guys said, the overlap with Clonus versus NMS. NMS is a more rigid disease. And the other interesting thing about NMS is it takes, roughly like days to weeks to initiate after offending medication. Serotonin syndrome takes sort of roughly 24 hours and can be even sooner. And so both time course and the Hunter criteria help you diagnose this. All right, so let's go back to his med list. So you guys talked about the fentanyl already. What medications, other medications do you think would you ask about in this person? These are just the meds you saw in Epic that morning. What else would you look for in their chart? Okay, great. Not on Haldol. Great. So Paul asked about tramadol. He was never on tramadol. He was never on trazodone.
Linezolid can.
Yeah. So Levi asked about linezolid. And so you review his chart and you find out about 2 weeks ago, he was on an 8-day course of linezolid. And then you also find out that he was on citalopram for the first 5 or 6 days of his hospitalization as an outpatient. That was an outpatient medication. So offending medicines for this guy, linezolid, citalopram, and the fentanyl as well, which causes serotonin syndrome. We'll talk about that more in a second. There's one other medicine on this list which is associated with serotonin syndrome, which I learned about this morning. Does anyone know what that medicine is?
I feel like Seroquel is too obvious. It's not really a serotonin agonist.
Carl's correct. Seroquel is too obvious.
I'm gonna say the H2 blockers because those do weird things.
Great. So Carl says the H2 blocker. The H2 blocker is not correct, but I like that he guessed.
Lovenox.
Lovenox, also not correct. So the answer is valproic acid is also a cause of serotonin syndrome, which I did not know till this morning. So let's talk about serotonin syndrome. So the way I was like trying to think about serotonin syndrome this morning is like how to actually teach about serotonin syndrome, because I think it's like one of those like semi-nebulous things that we talk about a lot. And there's a lot of medicines that cause it, and we don't see a ton of them in practice. So like the analogy I came up with, and I'm not sure this works, is like a huge iceberg, right? And this is like the top of the water right here. And so when you're scanning this person's chart for serotonergic medications, the big ones that we always think about, right, are SSRIs, SNRIs, and like MAOIs, right? These are the ones that like are really can't miss when you get into their chart. And then, so Mark says that analogy definitely doesn't work. I appreciate that. He didn't even see the end of it before he called me out. So these are the ones you see when you look at the chart, and that's like your quick scan. And then what other medicines do you guys associate with serotonin syndrome? Like what requires more thought when you look at the chart? Great. So this is why we're talking about it. So things that you may not know about or require more thought. So a lot of drugs of abuse. And so amphetamines are a huge one. So if you haven't admitted someone at Denver Health yet with a fever after taking amphetamines, that's one to be aware of. So amphetamines, cocaine, and then MDMA or ecstasy, all of those can cause serotonin syndrome by increasing your amount of serotonin in your body. Other big ones that we don't often think about, so the 5-HT3 antagonist, which we give to everyone in the hospital, which is Zofran, in high enough doses can cause serotonin syndrome. And then if we keep getting weirder, we get down into antibiotics, which is the one that now all of us know, which is linezolid. Linezolid causes serotonin syndrome because, believe it or not, it's actually an MAOI. It was made as an antidepressant and it didn't work. And then they repurposed it in the early 90s and found that it had antibacterial properties. That's why it crosses the blood-brain barrier. And then further down, you get into valproic acid and carbamazepine, which is not spelled correctly there. So why does valproic acid cause serotonin syndrome? Does anyone have any idea or guess? There's no way you should know this. So valproic acid increases the amount of tryptophan in your brain. It's a mechanism whereby it basically increases intracerebral tryptophan, and tryptophan is ultimately becomes serotonin. And so just another medicine to be aware of. We have a ton of people on Depakote or valproic acid at all of our hospitals. And if your person is fevering and you're sort of kicking out possible medications, consider valproic acid. There are a ton of medicines that do this. There's a really good New England Journal paper from 2005 that reviews it and has an even longer list of medications, but these are the ones that we'll probably see most commonly in the hospital. Any questions about serotonin syndrome?
What is fentanyl? One is that.
Fentanyl, yeah, why is fentanyl? So fentanyl is sorry, I forgot to include fentanyl, here's the whole purpose of this. So fentanyl is, does anyone know why fentanyl causes it? So it's a serotonin agonist, so it works directly on the serotonin receptor. And so fentanyl for high enough doses for long periods of time will cause serotonin syndrome. So why did fentanyl cause it in this guy? So does anyone know where fentanyl gets stored in the body? Yeah, so fentanyl is stored in the fat. So this gentleman had a BMI of 50 and was on roughly 200 micrograms per hour for weeks. And so the theory was that he was sort of slowly leaking out fentanyl even after the medicine was discontinued. So you guys have diagnosed serotonin syndrome. How do we treat serotonin syndrome?
Stop the medicine and give him cyproheptadine if it's severe.
Nice. So Levi says, stop the medicine, which is great. And then Levi brings up this question of cyproheptadine. So I'll be interested if Dr. Kearns is still on his approach to cyproheptadine, but there is almost no evidence that cyproheptadine is effective. And in fact, I don't think our toxicologists at the U like to use it. And the reason is if you don't know for sure what the intoxication is, cyproheptadine is an anticholinergic medicine because it's a first generation antihistamine. And so you can actually make an anticholinergic toxidrome worse. That being said, there is some data to say cyproheptadine in sort of mild or moderate cases or severe, but again, the data is not great, which is why the number one treatment for these people is benzos to sedate them, and then cooling, which can include basically needing to intubate and paralyze if severe enough. Dr. Kearns, do you have thoughts on cyproheptadine?
Yeah, Danny, I would second that. I would say it's one of those questions that frequently gets asked, but very rarely gets utilized. And typically it's exactly as you propose. A GABAergic drug like benzos is first line, or propofol sometimes will be added in addition to high dose benzos. And then the third line is typically like neuromuscular blockade to control it if it really is sort of profound hyperthermia that goes, or hyperpyrexia that goes along with it. A couple of other thoughts, like, and these are kind of all stories from life. Something to keep in mind is that, one particular SSRI, and that's Prozac or fluoxetine, had a very, very long half-life. It was why it was very attractive because people were less likely to withdraw from it. But the half-life of the metabolites can be up to like sort of 6 to 8 days, as I recall. So you can have a person and stop their fluoxetine, not that many people are on that, and get started on linezolid 4 or 5 days later, they can still get serotonin syndrome. So keeping in mind what medications patients were on before they came into the hospital is really, really critical in this diagnosis. As you mentioned, lots of drugs of abuse, and if people are messing around with cough syrup and stuff like that, that's a common cause. And ocular clonus, pretty rare. Keep in mind the call that you're going to get when a person has ocular clonus is the nurse on the floor is going to say, hey, this person's having a seizure. I've only seen it one time. It was a psych patient at the VA that was on 2 or 3 serotonergic agents, who then had the wherewithal to take off his fentanyl patch and chew it for fun. And he came down to the VA ICU with seizures. But he had ocular clonus, but you could engage with them and interact with them. And that sort of revealed itself to us that this was serotonin syndrome as opposed to status epilepticus. So.
Wow. Thanks, Dr. Kearns. So just a reminder, take fentanyl patches off your patients if you're concerned, and don't let them eat the fentanyl patch. All right, so let's do our last case of the day. So we've got this potion up here. We're going to scroll down, and this case right here was completely a new toxidrome to me, so excited to talk about it. All right, you got a 41-year-old man who was sitting at his desk at work when he let out a grunt or a moan. His coworkers walked in and found him unresponsive with agonal respirations. CPR was started by his coworkers. When EMS arrived, he had a pulse, but his GCS was 3. Received naloxone without response. So what do you guys think hearing this story? What toxidromes come to mind? Okay, benzos.
It's still opioids.
Great, so still opiates. That's a pretty good list. That was like my initial thought. Like you're hitting the common things, like those are 2 pretty big buckets, and those are the things we see most often. So this is where the story gets more interesting. So, let's see this. So in the ED, he is intubated for airway protection with etomidate and rocuronium, and then started on propofol for sedation. Sorry, I moved this over so people can see it over here. He is transported to the CT scanner for head imaging when he became acutely hypotensive. He subsequently had a bradycardic arrest ×2 with ROSC both times, ultimately got 7 rounds of CPR. He is stabilized after ROSC, and he is transferred to the MICU intubated. In the MICU, he wakes up almost immediately. He points to his tube and he says, "Extubate me."
While I'm standing over him with a central line.
While Kate Jankowski is standing over him with the central line. So what do you guys think? What toxidrome could we be dealing with here? It is okay if you've never heard of this. I had never heard of this until Kate and her team told me. So OD of beta blocker or calcium channel blocker, I like it. So great thought. So maybe he's hypotensive, he's in shock. And Melanie says her diagnostic reasoning says he probably wouldn't get better that quickly, which is a great thought. That's really important for this. Jake says cyanide, I like it. Thinking outside the box. Yeah, he didn't say extubate me. Dr. Kearns, he pointed to it and mouthed extubate me, or said take it out. I took some dramatic liberties with that story. All right, so Kate, what did you guys when you guys talked to this guy's family on the phone? What did you find out next?
He's been working really hard to build muscle. He takes testosterone and the one that prevents gynecomastia and the steroid.
Cool. So he takes it. Go ahead.
Oh, and something called Potion 9.
So he takes testosterone and something called Potion 9. Potion 9, you Google it and you find out that it is something in it called 1,4-butane-diol. You get that because there are a bunch of Google articles about people getting put in prison for selling this illicitly, but there's nothing about the pharmacology. So you Google 1,4-butane-diol, and does anyone want to take a guess what 1,4-butane-diol becomes? So 1,4-butane-diol ultimately becomes a medicine called gamma hydroxybutyrate, or GHB. So this gentleman was coming in with a GHB overdose. So what is 1,4-butane-diol? So 1,4-butane-diol is an industrial solvent, and it became popular after GHB was banned in the 80s and 90s because it was killing people and it was leading to some absolutely horrible things. But importantly, this whole process happens really quickly. So this is very rapid. And so if you take 1,4-butane-diol, you are almost guaranteed to get GHB in your system within minutes. And so what does GHB do? So GHB is a precursor to GABA. And so increasing the amount of GHB in your system will increase the amount of GABA you have in your system and will do everything that GABA does. It's an inhibitory neurotransmitter, it'll make you more tired, encephalopathic, et cetera. So what do people use 1,4-butane-diol for? So like Kate brought up, the big cause now is bodybuilding. So if you're in Ben Treflick's basement and you're trying to get larger, bodybuilding. And the other thing it's used for is it's marketed as a weight loss supplement. It's marketed as like an organic supplement for food. And then it's got some like various like weird like sexual side effects that various places have marketed for as well. Needless to say, it doesn't do any of these things. What it actually does is it has sort of this combination of symptoms of vomiting, incontinence, and then you get into like everything that GABA does. So confusion, ataxia, general encephalopathy, and then sort of weirder stuff is it causes combativeness and agitation and bradycardia. And so this entire group of symptoms is pretty sort of like classic for GHB overdose. The really interesting thing about GHB and the reason that toxicology and the ED recognize this so quickly is that people wake up. If they don't die, they are better quickly. And so a person who has this toxidrome, they get intubated, but then within hours, they're sort of back to their baseline or close to their baseline. That's pretty consistent with GHB because of its sort of speed of metabolism. So how do you treat GHB overdose?
I think the other thing I like in this case too is that you can see a lot of like apnea spells where they just kind of stop breathing for a while, and like they're telling us that like you just kind of have to be okay with it and they'll start breathing again. I think this guy like for a minute and a half was like fighting the ventilator, you can breathe, and then you like take a big breath in and after for a while.
Wow. So for those people that couldn't hear, Evan just said that Tox told him that you just have to be cool with apnea all of a sudden. And so you need to basically just let them be apneic and they will eventually come back. Which is also the reason why GHB has killed people is that they have the combination of apnea, encephalopathy, and then they aspirate or vomit. And the triad of those three things often can kill you. So that's terrifying. So how do we actually treat it though? Kate, what did you guys do?
So we did a phenobarbital taper. Baclofen is also used, but he wasn't taking Venom. Oh, sorry. For toxicity, we waited like an hour.
Cool.
But then he had withdrawal. That we used the phenobarbital.
Great. So Kate beat me to the teaching point, which is great. So for toxicity, you don't have to do anything besides support them via your usual like ICU supportive measures. The big thing is that these people will withdraw and they need medicines for withdrawal. And so, Kate, what is their withdrawal syndrome similar to? Yeah, great. So it's a similar mechanism to, or it's a similar presentation to alcohol withdrawal. And the other really interesting thing is if you go back up to their, this kind of pathway up here, like the 1,4-butanediol to GHB, you'll notice that this pathway looks very similar to the way we metabolize alcohol. And so the other kind of terrifying thing about this is if you take a kind of a co-intoxication, if you take alcohol with this, you can slow this whole pathway down. And so you can either sort of delay the amount of time you have GHB in your system, or you can have a delayed onset of the GHB when it happens. People aren't exactly sure how the pharmacokinetics work, but alcohol will inhibit both of these things. So Kate, you guys treated this guy for GHB withdrawal with a phenobarbital taper, and how long did that take before he was better?
He was showing improvement on 30 hours, but was hospitalized for 4 days.
Great, so 4 days of withdrawal for GHB, which is actually pretty classic if you look at the very kind of limited data. And so the thing to know here is that GHB, the withdrawal will be probably more problematic if they survive the initial event. And in order to withdraw from GHB, you need to basically be taking it around the clock. And so Kate and her team, as well as the addiction team, did a great job asking this guy those questions. And he was basically taking GHB every 4 hours, every 4 to 6 hours for basically a year. And that's certainly enough for people to withdraw from GHB. And so he was taking that for a long time, unclear whether he just overdosed at work or had stopped taking it or took too much compared to normal. But he had this very combative, he yelled, he screamed, and then he went apneic and was soon thereafter arrested. Any questions about GHB?
A couple other things that so I think for GHB, you have to take it that frequently because you withdraw at 1 to 6 hours. You know, so he had like kind of tried to self-taper a couple of times and the furthest he could get was like 6 hours. So that's just what I do off. Another thing Kate is GHB acts more on the GABA B receptors than it does on GABA A, and so you can they've used benzodiazepines before, but it's just like insane amounts of benzos because it's not it doesn't act more on GABA A than on GABA B. So that's always good.
Awesome, that's great. So what Evan was saying for those that can't hear is that GHB works more on GABA B. GABA B is better targeted by phenobarb and the barbiturates versus GABA A. And then Kate, you said this earlier, what other medicine targets GABA B? Great, so baclofen also targets GABA B. And so in this really excellent tox note, they mentioned that if they were struggling with phenobarb, they could consider including baclofen in the taper as well, or even do baclofen for cravings, which seems like a fairly bad idea. Kate and Evan, anything else you guys learned from this case?
We were also thinking the majority arrest might have been after protocol induction and that component, are not effects there, not actually the toxicity, but the apnea.
Gotcha, so you're saying that the propofol, so it takes GHB and then the propofol in addition to the GHB, whatever causes a bradycardic arrest. Wow, not great. But a really fascinating case. And I think GHB, thankfully, is not that common in toxicology cases. A lot of the people, unfortunately, don't make it to the hospital because they're found dead. But hopefully, if you guys see this in the future, or you see someone wake up after suddenly becoming aptic and arresting, you will have that on your differential.
They're asking if it's also used as a date rape drug. So
Yeah, so GHB also uses as a date rape drug. It actually is like the date rape drug. If you were to if ask people like, do you think you were given a date rape drug, et cetera, it is GHB is the one that we're commonly referring to. And GHB has about 100 different names if you look in kind of GNC products and stuff, and it's often caused by different names to get it past regulation. So asking people to bring in the supplements if they have them are helpful because we cannot test for it in our labs. Jordan says, is there any diagnostic accuracy? Is it just history and physical? Yeah, so it's just history and physical. There is no lab that we can run that detects this. And then Sam King is saying that Kate also diagnosed serotonin syndrome in someone this week who had spontaneous ankle clonus on a fentanyl drip while intubated. That's what I'm talking about, Kate. So Kate, even before the conference, knew what serotonin syndrome was and crushed it. Yeah, so I will say from this conference, you guys will see serotonin syndrome in residency. It's not uncommon. And just recognizing the medicines is the huge first step to knowing what it is. Cool. Thanks, guys.